Welcome to this explainer. Medical coding for urology can honestly feel a bit like you're trying to navigate a giant maze blindfolded, right? But today, we are going to change that. We're going to take these dense, sometimes intimidating rules and transform them into a clear, logical, and highly visual pathway. We'll trace the journey of a procedure right from the anatomical crime scene all the way to the final coding decision. Because whether you're dealing with a routine scope or a really complex laser intervention, once you understand the why behind the code, everything just naturally falls into place. Let's get started.
So here is our roadmap for today. First, anatomy foundations. Second, cystoscopy, or the difference between looking and doing. Third, lithotripsy approaches. And finally, prostate clinical pathways.
All right, kicking things off with Section 1, Anatomy Foundations, where we map out the structures.
Let's dive right into this. Precise coding absolutely always begins with precise anatomy. Think about the urinary tract top down. It starts up high with the kidneys, which are busy producing urine. Then, the ureters act like plumbing pipes, transporting that urine down into the bladder. The bladder stores it, and finally, the urethra expels it from the body. Now, what's really fascinating here is how directly this physical anatomy dictates the procedure type you'll be coding. If your surgeon is working all the way up in the kidneys or the ureters, you're generally looking at procedures like ESWL or percutaneous interventions. But if they're working down in the bladder and urethra, well, now you've entered the realm of cystoscopy. Always establish your anatomical location first.
Moving just a bit further down, we hit the prostate gland. This is an accessory organ in males located right below the bladder, and it intimately surrounds the prostatic urethra, kind of like a donut wrapping around a straw. The clinical significance of this specific location is literally massive. Because it wraps around the urethra, any enlargement, like benign prostatic hyperplasia, or BPH, will physically squeeze and obstruct that urine flow. Prostate cancer can also cause obstruction, but of course, that triggers a completely different clinical pathway. So you have the exact same gland presenting three very different clinical stories: benign enlargement, severe obstruction, or cancer. And each one leads us down a totally different coding reality.
Moving on to Section 2, cystoscopy, and the crucial difference between diagnostic and therapeutic.
Okay, so here we need to establish the absolute golden rule of endoscopic coding. You have to distinguish between a surgeon who is merely looking and one who is actually doing. A great clue is the equipment itself. A flexible cystoscope is super maneuverable. It's usually used right in the clinic with just a little local anesthetic gel, and it's primarily for diagnostic evaluations. It's a relatively comfortable way to just look around. A rigid cystoscope, on the other hand, is literally a straight metal telescope. It generally requires regional or general anesthesia because it has these larger working channels that allow the surgeon to pass surgical instruments through it. So if a rigid scope pops up in your operative note, it's highly likely you were dealing with a therapeutic procedure, where the surgeon is actively intervening.
Which brings us to CPT code 5200. This is your base code for a purely diagnostic cystoscopy. You only ever report 5200 when the scope is used exclusively to inspect the urethra and bladder for abnormalities, with zero therapeutic intervention performed. None. If the surgeon goes in, takes a look around, and then decides, hey, I need to biopsy this or grab that stone, that initial diagnostic look is automatically bundled into the therapeutic work. Do not bill 5200 separately in that case.
Well, what happens when they actually do something, like a biopsy or fulgurating a bladder tumor? Simply put, size dictates the code. If it's just a standard biopsy without fulguration, or if they're fulgurating a tiny lesion under 0.5 centimeter, you're going to use 52224. But if the surgeon is actively fulgurating tumors, the codes scale up based on the physical size of the tumor. Use 52234 for small tumors up to 0.5 centimeter, 52235 for medium ones up to 2 centimeters, and 52240 for large tumors over 2 centimeters. So always be scanning that operative note for specific measurements.
Okay, time for a quick knowledge check to keep us on our toes. Imagine you're auditing an op note. The surgeon takes a biopsy of a specific bladder lesion and then immediately turns around and performs fulguration on that exact same lesion. So, how do we code this? Do you bill for both the biopsy and the fulguration?
The answer is absolutely not. You report only the fulguration code. The lesser procedure, the biopsy, gets completely absorbed into the more comprehensive fulguration procedure on that same lesion, which logically makes sense, right? The tissue is going to be destroyed by the fulguration anyway. Now, quick caveat. If the surgeon took a biopsy from one lesion and then moved over to fulgurate a completely different lesion somewhere else in the bladder, that's when you code both.
and you'd typically slot modifier 59 on that biopsy code to prove it was a distinct, separate site.
All right, Section 3, lithotripsy approaches, where we match the approach right back to the anatomy. And this brilliantly illustrates that when you're coding for stone treatments, your accuracy relies almost entirely on how the surgeon physically got to the stone. The approach is literally everything. Let's look at extracorporeal shockwave lithotripsy, or ESWL. Here, external shockwaves are beamed from outside the body to crush the stone inside. No scope ever enters the body. That's CPT 5590. Contrast that with laser lithotripsy, or URS. In this case, the surgeon passes an endoscope right up the urethra and bladder directly into the ureter, and they use a laser to blast the stone under direct vision. That highly endoscopic approach is coded as 52356. But what if the patient has one of those massive, incredibly complex staghorn kidney stones, the kind an endoscope just can't handle? That's when the surgeon pivots to percutaneous nephrolithotomy, or PCNL. Here, they literally create a percutaneous tract straight through the skin of the back directly into the kidney to grab those huge stone burdens. Because this is a highly invasive, direct approach, it pushes us straight into CPT codes 5080 or 5081, depending on just how complex the stone is.
Because stone procedures can get super complicated really fast, there is a mandatory 5-step workflow that makes coding them pretty much foolproof. Think of it as your checklist. 1. Where exactly was the stone located? 2. What approach was used? ESWL, URS, or PCNL? 3. And this is absolutely critical. Was the stone just fragmented, or was it fragmented and extracted? 4. Did they leave a ureteral stent behind? And 5. Does the documentation actually support the code you're about to pick?
Let's look at a common, real-world pitfall with that third question. Let's say you're auditing an op note. The surgeon clearly writes that the stone was fragmented, but then, nothing. The note just abruptly ends. It never explicitly states whether those fragments were left in there to pass naturally or if the surgeon manually retrieved them with a little stone basket. What do? You have to query the physician. Seriously, never, ever make assumptions here. Why this matters is pretty straightforward. Extraction status completely changes your code selection, which directly changes the reimbursement. Fragmenting a stone is one specific scenario. Actively basketing and removing those fragments is an entirely different one with a different code. Incomplete op notes are basically the enemy of accurate coding, so always ask for clarification.
Which brings us to our final stop, Section 4, Prostate Clinical Pathways.
Let's think back to our anatomy for a second. Because the prostate intimately hugs the urethra, any benign enlargement is going to physically squeeze that pathway, causing all those classic obstructive symptoms we code for every single day. The physical anatomy absolutely forces the clinical indication. Let's actually trace these clinical routes step by step, because the indication dictates the procedure, which dictates the code. If a patient comes in with an elevated PSA or some suspicious imaging, that routes us straight to a diagnostic, TRUS-guided prostate biopsy. That's CPT 55700 for the biopsy itself, usually a 12-core systematic template. And don't forget, if documented separately, you also have 76872 for the diagnostic ultrasound and 76942 for the ultrasonic needle guidance. Now, what if the indication is BPH causing severe bladder outlet obstruction? Well, now we route to therapeutic transurethral interventions. And here's where we compare our heavy hitters. You have a TURP, CPT 52601, which uses an electrosurgical loop to literally carve out obstructing adenoma into chips that get sent to pathology. Then you have HoLEP, CPT 52649. This uses a holmium laser to beautifully enucleate the lobes right off the capsule, and then they morcellate or grind up that tissue in the bladder for retrieval. Or you might see a GreenLight laser PVP, CPT 52648. This completely vaporizes the obstructing tissue using high-powered photoselective energy. The big difference here? GreenLight leaves almost no tissue specimen behind for pathology. And finally, if the diagnosis is localized prostate cancer, the patient routes completely away from these endoscopic relief procedures and straight toward radical cancer therapy. So remember, track the indication, track the energy source, and track the tissue specimen.
As we wrap up this explainer, I really want to leave you with this foundational truth. Good documentation leads to accurate coding, which directly leads to proper reimbursement and strict audit compliance. By deeply understanding the anatomy, the surgical tools, and these clinical pathways, you aren't just memorizing lists of numbers anymore. You are actually reading the surgical reality. So the next time you sit down with an operative note, ask yourself, are you just matching numbers, or are you truly seeing the surgery? If you want to keep mastering the clinical reality behind these codes and prep for our next segment on radical prostatectomies, be sure to like, share, subscribe to Decode Healthcare with Harshal. Keep decoding, and I will see you in the next one.